let's get started. On behalf of the UCSF Research Coordinating Center and Investigator Development Unit of the NIMHD, Multiple Chronic Diseases Consortium, I'd like to welcome you to our monthly webinar. Before we get started, Adele, would you mind sharing your screen? Great. We would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to contribute their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Okay, thank you. Well, today we're honored to have Dr. Dean Schillinger speaking to us about health literacy constructs in chronic disease disparities. Dr. Schillinger is an internationally recognized health communication scientist and an expert in chronic disease prevention and control, who has authored over 300 peer-reviewed scientific publications. He directs the UCSF Health Communications Research Program, serves as site director for the NIH Center for Diabetes Translational Research, and is the principal investigator for CDC and NIH-funded projects in diabetes-related policy, and also to develop measures of health literacy using computational linguistics and machine learning. Dr. Schillinger currently co-chairs a subcommittee of a federal advisory commission related to harmonizing diabetes policy across federal agencies. He's also been instrumental in local policy health regulation of sugary drinks. He is a co-founder of the UCSF Center for Vulnerable Population, whose mission is to promote health of the vulnerable populations through discovery, collaboration, advocacy, and policy change. Dr. Schillinger, we're very happy to have you, and we welcome you.
Thank you, Dr. Khalili. What you failed to mention is we're both parents of twins. That's the most important accomplishment of our lives. It's a pleasure to be here. I can share my screen, I think. Is that right?
Yes, yes.
How's that?
Yes, that is perfect.
Okay, good. Yes, it's a pleasure to be here. I'm very excited about the role of this coordinating center and all the participating P50's work. Very critical, and I hope that my talk today will be aligned with your mission and help you as you think through your important translational research efforts. The outline for my talk today is to describe two forms of health literacy and to distinguish them from each other. That's individual health literacy and public health literacy, and share a unifying framework that elucidates the pathways between the social determinants of health, health literacy, and health inequities in non-communicable diseases, and then provide examples in each of health literacy and equity activities that are embedded within this framework across multiple NCDs. That includes a focus on diabetes, as well as intersections with oral health and mental health. Before I begin, much of this talk is going to focus on the health of marginalized populations, and I wanted to define that term in a particular manner to frame today's talk. And that is that I use the term marginalized populations to describe subgroups of the larger population that, because of social, economic, political, structural, geographic, and/or historical forces, are exposed to a greater risk of risks and are thereby at a disadvantage with respect to their health and healthcare. Now, that is obviously an overly academic and epidemiologic perspective, but I think it's a very important one to use to frame the remainder of this discussion, because much of what we're talking about here is the disproportionate risk of exposure to unhealthy context, whether that's unhealthy context in the community setting or unhealthy context in the healthcare setting. So individual health literacy has been defined as the degree to which an individual has the capacity to obtain, process, and understand basic health information and services needed to make informed health decisions. It has commonly been thought of as including three domains of communication: oral communication, written communication, and numerical communication. But increasingly, we recognize that digital forms of communication are increasingly important, whether it's searching online for health information or communicating with your clinician via a patient portal. In addition, there's been a very successful campaign over the last decade to shift the focus of the health literacy discourse away from, quote unquote, the deficiencies of the patient and more towards the imbalance or mismatch between the what are felt to be fixed capacities of the patient and family, or their level of preparedness at the time that they first meet healthcare, in comparison to the demands that the healthcare system places on these patients to help them self-manage or manage their condition. And so increasingly the focus of the health literacy research has been on reducing this mismatch by affecting the healthcare system's response to all the patients that it serves. This has led to the construct of Health Literate Healthcare Organizations, which is a concept that we put forward through the National Academy of Medicine, which defines the attributes of healthcare organizations to meet the needs of patients of all health literacy levels. Nonetheless, this still is focused on the construct of an individual's health literacy level. In contrast, the construct of public health literacy has been defined as the degree to which individuals and groups, including society as a whole, can obtain, process, understand, evaluate, and act upon information needed to make public health decisions that benefit the entire community. So the target populations for these communications include the public, and the purpose is to improve the health of the public as opposed to an individual patient. Its aims are to engage more stakeholders in public health and prevention efforts, and to address the upstream determinants and mediators of health. And it is a multidimensional construct with conceptual foundations that include an understanding of the socio-ecological model, critical thinking skills, and a civic as opposed to a solo individual orientation. Okay, that's the dry part of the talk, hopefully, these definitions. Now, we put forward what hopefully is a unifying conceptual framework that in and of itself, while it appears to be two-dimensional and linear, is really a tricky way of showing a three-dimensional socio-ecological model. But health literacy in the center here is portrayed as being in the middle of pathways that connect social determinants of health with distal health outcomes. And there are two predominant pathways. On the right is the individual health literacy pathway. It involves the development and interaction of patients with organizations that have different degrees of health literacy themselves, different degrees to which they are meeting the needs of patients with high and low health literacy, and the resultant healthcare access and quality that the patient with those health literacy needs will experience. And depending on the extent of immersion in becoming a health literate healthcare organization, that individual patient's health outcomes will be impacted, and the degree of health disparities will be determined. That is one pathway, and it is subject to policy considerations and policy interventions that affect the delivery of healthcare. And many of you are working on healthcare policy interventions. On the left side of the pathway involves what we normally think of as the socio-ecological model of health, and that is that an individual's health is determined in large part on the balance between the structural resources that they have at their disposal and the life course exposures that they are subject to in their homes, families, and communities. And the degree to which these exposures and resources are made available to populations is a function of social policy. And so in concert, individuals' health outcomes is a function of the health literacy that we have as communities to change the structural resources and exposures that our populations are subject to, as well as the health policy concerns that determine healthcare quality and access. And I'm going to now discuss sort of two examples of work. First, one that is focusing on the right side, and the second focusing on the left side. So what do we know about individual health literacy? And here I'm going to use the example of diabetes. We know from prior research that limited health literacy, when measured at the individual level, has been associated with a higher prevalence of diabetes. In fact, among people with diabetes, the prevalence of limited health literacy ranges from 15 to 50%, depending on the healthcare setting in which the studies have been conducted. Rates, not surprisingly, are highest in the elderly, among marginalized populations, and in public settings like the ones Dr. Khalili and I work in, public hospital at San Francisco. And research has shown that individual health literacy is associated with a range of diabetes outcomes, including blood sugar control and diabetes complications, and there are multiple pathways that likely account for these disparities. However, it has been shown that the communication attributes of health systems likely account for some of these health literacy-related disparities in diabetes outcomes. To give you a sense of some of this research, we carried out a study at San Francisco General Hospital that showed that patients with limited health literacy in the sky blue here are 2 to 3 times more likely to have report that they do not understand the words that the doctor uses, that the doctor does not give them test results with sufficient explanations, that they are confused about their medical care, and that their doctor more often has problems understanding the problems that they as patients would have in carrying out the recommended treatment plan. Now, these are questions on the CAPS survey type instruments, which, as you know, tend to have a ceiling effect. So anytime you see 20, 30% of patients reporting dissatisfaction on these instruments, it's not noise, it's a real signal. Now, individual health literacy has become even more important in our digital age. Electronic health records, as you know, are now ubiquitous, and patient portals are penetrating nearly every health system. Patients and clinicians can now communicate through patient portals via secure messaging, and this itself requires a certain level of health literacy, so-called digital health literacy. And communication-sensitive chronic conditions such as diabetes often require between-visit communication, and that's where secure messaging has been most useful to patients. However, no research has employed any approaches to try to harness these messages to understand anything about the attributes of patients or their clinicians in terms of what they bring to the encounter. And insofar as limited health literacy is an important mediator of healthcare disparities, we wanted to mine the secure message data of a large health system to see if we could quantify the health literacy of patients and, in parallel, the linguistic complexity of their physician's language, so as to be able to understand the degree to which that healthcare system is aligning their communication to better match that of their patients. So I'm going to share with you, as this first example of the pathway on the right, the healthcare system pathway of individual health literacy, some work we've been doing around the construct of what we call precision communication, looking to see if physicians adapt their language to meet patients' health literacy. This is part of a National Library of Medicine study called the ECLIPSE study. Now, the background, as I mentioned, is that communication is a fundamental pillar of care, and that really the goal of communication in outpatient care in non-communicable diseases, in part, is to arrive at shared meaning with your patient, whether that's shared meaning around the diagnosis, the treatment, the barriers to care that they have, et cetera. And that without reaching shared meaning, the effectiveness of healthcare is undermined. Little research, however, has examined physician-level skills and practice styles that might facilitate shared meaning or inhibit shared meaning. And we don't know how often physicians use complex language. It's sort of almost a trope to think of doctors as using jargon, but very little research has actually examined this question. So we sought to study whether linguistic complexity matching, or so-called concordance between physician and patient in terms of their language, can promote shared understanding by harnessing a treasure trove of de-identified secure messages exchanged on the patient portal. Now, the methods that we used, we studied over 4,000 English-speaking diabetes patients and over 1,000 primary care physicians. So on average, physicians had about 4 diabetes patients in their panel, involving a corpus of secure messages of over 200,000 secure messages exchanged between them. And we applied measures that we developed of patients' health literacy and physicians' linguistic complexity that we generated via computational linguistics, including AI and machine learning, and classified dyads as either being concordant or discordant with respect to their language. Now, I should tell you that we were agnostic to the semantic meaning of the language here. This is just using linguistic indicators of complexity that have been developed in other fields over decades. Over 200 linguistic indices that can capture attributes of language. That was our predictor. Our outcome was the CAPS measure of patients' reports of physician communication, whether they understand or don't understand their doctor. And we examined whether health literacy and linguistic complexity discordance was associated with poor communication after adjusting for other factors. We further examined whether certain physicians have a dominant style, whether they tend to match with all of their patients or only match with the low health literacy or the high health literacy patients, to see if there was any strategy that was also associated with better communication. Now, whoops, we're not progressing here. There we go. Now, I want to take a moment to talk about how complicated this research question is and the methods that we use. And this metaphor I'm going to use here of an eclipse is not unique to our research. This is really a metaphor for all scientific discovery. And so I just want to remind people, obviously, the sun is something important in our lives, but we actually can't look at it directly, right? We have to be able to look at it through a filtered lens that can only occur during an eclipse. And so imagine us as scientists standing on Earth trying to understand the sun. We have this moon that gets in our way, and we can study the sun by studying the shadow that the moon casts or the filtered light in the penumbra of the moon. We cannot look directly at the sun. In other words, as scientists, we cannot directly observe truth. We must infer truth through the filtered lens of our scientific process. And again, depending on where you're standing on Earth, you can appreciate different aspects and attributes of the sun. And there are trade-offs in our observations depending on where you're standing. And this is certainly true with health literacy. There is no universal truth that has been arrived at yet in terms of health literacy. It depends on your perspective. And our perspective today is the perspective of language and the analysis of language as conveyed on a patient portal. So what is it that we did here in this study? So if, again, we follow this metaphor, our sun parallel is the construct of health literacy. We are trying to understand health literacy and the truth of health literacy. Our specimens to understand that truth, in this case, are language, written language, as documented in the patient portal, at the patient, generated by the patient and generated by their primary care physician. Our tools and methods, our pipettes, our microscopes, are the natural language processing linguistic indices that can be applied to natural language, and using machine learning and AI can generate measurements like the health literacy measurement and the linguistic complexity measurement. We then, again, standing on Earth, can use these novel measures and validate them against other things that we can observe more directly, like people's health, their self-reported communication experiences, as well as expert ratings of their language. So we can attempt to validate these measures using other things that we can directly observe and measure. And based on that, we can use these novel measures to make inferences. But as you can see, there are a lot of potential voltage drops along the way between the observation and the inference. So keep that in mind as I reveal the inferences we've made. The first thing we found after we validated our measures of health literacy and physician complexity, including cross ethnicity validation, with respect to different race ethnicities of our sample, we found that among low health literacy patients, about 47% had a physician whose language was concordant with theirs. Among high health literacy patients, 56% had a physician whose language was concordant with theirs. When we looked at the importance of discordance in determining poor communication, we found that indeed discordance was associated with poor physician communication for patients who had limited health literacy. About a 40% increased odds of having poor communication if your patient spoke in a language that was more complex to your health literacy. In addition, with respect to the physician style, we found that those physicians that employed a universal tailoring style, meaning they were more likely to adapt their language to meet the language of their patients, the low health literacy patients and the high health literacy patients, was associated with better communication for all patients. In other words, the physician who seemed to be attentive, mindful, and listening to the language that their patient used, and then adapted and responded accordingly, generated better communication scores. In fact, we found an interaction between dyadic communication and physician styles such that those patients with low health literacy who both experienced concordance with their physician and who were cared for by a physician who tended to universally tailor had communication scores that were equal to that of their colleagues who had high health literacy. In other words, the combination of style and behavior eliminated communication-related disparities in the sample of diabetes patients. So this was the first study to provide empiric evidence that physicians' receptive and expressive skills, individually and in combination, can influence communication outcomes. And patients with low health literacy are particularly sensitive to this kind of matching. And patients of both low and high can benefit from this physician's style. And so we argued in this paper that we were happy to see was published in the Science family, which is pretty good for a communication article. We argued that the construct of precision medicine should include the domain of precision communication. So we've now, I now provided an example of research in non-communicable diseases that is relevant to the pathway on the right. What does it mean to be a health literate healthcare organization? In this case, what does it mean to have clinicians who can adapt their communication to meet the health literacy needs of their patient? That's, again, addressing the demand-capacity mismatch. For the next part of my talk, I'm going to focus on the second pathway, the public health literacy pathway, where we're looking at the environments in which people live that can affect their life, both as a consequence of the exposures they are subject to and the resources that they have access to. And I'm going to do that in the domain of oral health. An exercise that I was invited to participate in at the National Academy of Medicine related to the integration of oral and general health through health literacy practices. Now, this was a National Academy of Medicine workshop whose express goal was to apply a comprehensive framework to enable the integration of oral health into primary care, such that it was not sort of the stepchild of healthcare, but became part of what we do with physical health, mental health, and now oral health. To my surprise, when I looked at the agenda, I noticed that this was all clinical. There was really nothing that related to the integration of public health principles, the involvement of public health principles into these integration efforts. And so I argued that we needed to have a public health literacy component to this workshop that involved this public health literacy pathway. And so I want to share with you the arguments we made and the paper we put out with some colleagues who are actually part of this coordinating center, including Stuart Gansky and others. So we argued first that the reach of dental care is incredibly limited. And this is not unique to dental care. This is true for healthcare in general. There's an ecology of care model that's been created for dental care as well. And as you can see, looking at these smaller and smaller boxes, only a small proportion of individuals in the United States actually visit a dentist's office, visit a physician's office, a dentist's office, et cetera, et cetera. And among those who visit a dentist's office, as I'm sure you know, markers of marginalization are strongly associated with lack of having a visit to a dental office, even in the face of high dental needs. So limiting the NAM integration workshop only to clinical care would significantly hinder the impact of such efforts in terms of population's oral health. So why is harnessing public health literacy critical for the integration efforts? As I mentioned, the access to integrated care is helpful, but would of course be insufficient. And in addition, most oral health, physical health, and mental health problems are actually driven by common shared risk exposures. And preventing these exposures that affect all three health dimensions would be a very efficient, clinically effective, and cost-effective approach. Furthermore, greater social marginalization elevates risk exposures that jeopardize all three dimensions of health, and disease burden in any of these dimensions will lead to downward economic mobility and create greater social vulnerability and marginalization, furthering the disease burden. So clearly, addressing these common social determinants and pathways can prevent risk exposure and reduce disparities, not only in oral health, but potentially in all three dimensions. And finally, secondary prevention for systemic diseases or oral diseases can yield collateral benefits for other diseases, as I'll mention in a moment. So the argument we made in this workshop, not surprisingly, is the argument that Tom Frieden made in his pyramid of health impact, which is if you only focus on the top of the pyramid, the clinical interventions and the counseling and education, you're missing an opportunity to address larger population level drivers of health and disease. Now, again, why is this public health literacy framework so important for integration? Well, prevention of exposures to the three health dimensions are possible. The examples that we laid out are diet, specifically added sugars, which obviously are associated with all three dimensions of health, unfluoridated water, which is associated primarily with poor oral health, but also as a consequence of poor oral health can lead to other chronic conditions, including mental health problems and systemic health problems. Tobacco use, which you all know is associated with all three, and then excess alcohol use, which is also associated with all three dimensions of health. So an example is sugar-sweetened beverage exposures. And just to give you a sense of how socioecological this problem is, this is the map of per capita income in the city and county of San Francisco. And the lighter the color of the region, the lower the income level is on a per capita basis. And I want to point out this upside down T pattern that we see with respect to per capita income. If we then show the soda expenditures in San Francisco, with the darker colors being at the top 80th percentile nationally, you see again a concentration of soda expenditures, and it would be very similar if we did soda marketing and soda billboards and soda advertisements in this same distribution. The diabetes hospitalization rate is remarkably different by location in San Francisco, again concentrated heavily with about a tenfold difference across the city between higher income and lower income hot zone neighborhoods with respect to diabetes hospitalization rates. And the oral caries pattern in children is exactly the same. So again, these are common exposures, common risk factors affecting a common population now at risk for oral health, systemic health, and mental health problems. And so having a public health literacy approach to these problems makes sense. In the soda tax discourse that took place a few years ago in the city and county of San Francisco and Oakland, and this is my daughter actually at City Hall at the press conference with the mayor of San Francisco and Oakland. I subsequently learned that she that day left her public school grounds and bought a bunch of Snapple for her class against the school rules. So you know, it runs deep, this stuff. The media coverage of the sugar-sweetened beverage tax was quite interesting insofar as it almost entirely ignored the oral health benefits of avoiding sugar-sweetened beverages. And if you look at the cost effectiveness of sugar sweetened beverage taxes, one of the most costly health problems that it does prevent are oral health problems. So when oral health did appear, it was typically mentioned in passing, and it only was mentioned less than 2% of the time in media spots about the tax. So we need to do more to integrate oral health in our conversations around public health. A good example of this is in a campaign that I'm involved with called the Bigger Picture Campaign, and we don't have enough time to show you some snippets here, but I want to point out this is a spoken word campaign against diabetes, to prevent diabetes through a socio-ecological lens. There's one poem of the 30 that we have now called Chocolate Smile, written by Marjane Kilpatrick when she was 17 years old, that I believe portrays both the social determinants of health and this idea of the integration of oral, physical, and mental health together in one 4-minute poem and video in ways that no PowerPoint presentation or paper or study could ever do. So I hope you take the time to look at Marjane's video poem called Chocolate Smile. What about non-fluoridated water as another common shared risk exposure? Bottled water is the fastest growing drink choice in the United States. We spend more than $100 per person per year on bottled water. It's more than 600 times more expensive than tap water, obviously more expensive than gasoline still. $12 billion spent in the United States during 2012, and it only rarely contains fluoride. In fact, of 640 bottled waters that meet FDA standards, only 15 contain fluoride. The FDA says that manufacturers may include, if they want, the following health claim: that drinking fluoridated water may reduce the risk of dental caries or tooth decay, but they do not require a warning label that states that bottled water does not contain fluoride. Consumers rather are encouraged to check with the bottler to find out if the water you drink contains fluoride. Many of us are using bottled water or purchased water to hydrate our children, for example. And in many communities, they don't have any choice but to use bottled water because of the state of the infrastructure of their plumbing and water system. Now, it turns out that the use of bottled water is associated with socioeconomic and racial inequities. 33% of U.S. adults drink bottled water on any given day. Non-Hispanic, Black, and Hispanic adults have about half the odds of consuming tap water. Non-Hispanic, Black, and Hispanic adults born outside the United States have double the odds of consuming bottled water compared with their U.S.-born counterparts and non-Hispanic white. Again, some of this is because of their belief systems. Others are because of the realities of their their tap water quality. A study in Maryland showed that low-income parents and caregivers of young children rarely drink tap water and do not give it to their children, but use bottled water. And they had limited understanding of the role of fluoride in caries prevention. What about filtered water? Well, it turns out most filtration systems filter out the fluoride. Reverse osmosis, distillation, aluminum, all remove fluoride. Carbon filters are the only ones that do not remove fluoride. How many of us knew this? I certainly did not know this before I started preparing for this workshop. So this is sort of addressing exposures, clear exposure, sugar sweetened beverages, water. What about upstream social determinants of health and integrating oral health literacy into those conversations? Well, we know that food insecurity in and of itself is a risk factor for oral health problems, as well as physical and mental health problems. Trauma and violence as well, low educational attainment as well. So we need to get oral health out of its silo and have a more health literate discussion around public health interventions. I want to talk a moment about mental health. There's been increasing attention to the ways in which dental health inequities hurt Americans through economic mechanisms. Toothlessness spells joblessness. Teeth, the story of beauty inequality and the struggle for oral health. Increasing amounts of research have shown that economic well-being and oral health are connected in very complex and reciprocal ways. 1/3 of adults, 138% or lower of federal poverty level, report that the appearance of their teeth and mouth affected their ability to interview for a job, versus only 15% of those with higher incomes. Fluoridation has been shown to increase earnings of women in natural experiments by 4%, with higher improvements for those women of lower socioeconomic status. A randomized trial in Brazil showed employers 2 images of the same person, one with no dental problems, the other one with uncorrected teeth, and those with dental problems were perceived to be both less intelligent and less likely to be considered suitable for hiring. Now, what about secondary prevention? It turns out there are very complex interrelationships between oral health problems and pre-existing systemic illness problems. For example, let's take diabetes, the exemplar condition where you have interrelated conditions of diabetes, periodontitis, which is gum disease, and the associated jaw problems, and depression. So hyperglycemia, or high blood glucose, negatively affects oral health, increasing the risk of periodontitis by 3-fold, alveolar bone loss, abscess formation, and poor healing. Severe periodontitis also negatively impacts blood sugar control and leads to inflammatory responses that can accelerate diabetes complications such as cardiovascular disease and kidney failure. In addition, the treatment of gum disease can improve blood sugar control, and the treatment of diabetes can improve oral health. Finally, tooth loss and diabetes each and together are potent triggers for depression, and treatment depression improves oral hygiene and diabetes control. The costs and disabilities related to the need for dental care and the care for diabetes complications have severe economic consequences, leading to stress, depression, and downward economic mobility. So we presented to the National Academy of Medicine this kind of reciprocal, vicious cycle diagram that shows how marginalization and economic deprivation is associated with the individual health dimensions of mental health, oral health, and physical health, but also the ways in which they feed each other in the process. So marginalization is associated with exposures, high rates of unhealthy exposures, and low rates of access to healthy resources that can lead to poor mental health, poor oral health, or poor physical health. And each of those in turn can interact with the sister disease, as I mentioned in the secondary prevention slide, leading to a process that both shows the flow of marginalization to poor health, but also feeds back into downward economic mobility and more marginalization and deprivation. So to return to our unifying framework here, I tried to illustrate this framework of the 2 ways of thinking about health literacy, the 2 ways of responding to the problem of health literacy. The first through a systems-based approach that involves the healthcare system, and the second through a systems-based approach that involves public health interventions and drivers, each of which independently and in concert can contribute to health inequities in non-communicable diseases. In conclusion, I hope I helped you take away today that there are 2 complementary so-called structural pathways that impact health literacy. One is the individual health literacy pathway that is sensitive to the healthcare system's attributes. The second is the public health literacy pathway that is sensitive to the ways in which society is constructed and the choices we make in apportioning resources and exposures. Each of these pathways can connect social determinants of health to health inequities and non-communicable diseases. Each has contextual and societal implications. One addresses the common and shared risk factors and exposures for NCD prevention control at the population level. The other addresses health system factors for NCD prevention control at the clinical level. And with that, I'll stop and we can open it up for questions or discussion or critique. Thanks very much.
Thank you, Dr. Schillinger, for that wonderful presentation. I'd like to open up the floor for any questions that the audience may have. And if not, we'll go ahead and ask some of the questions in the chat. Okay. Dr. Schillinger, regarding your precision communication article, There was a question regarding examples of concordant and discordant communication styles. Could you provide us with some examples of such?
Is the question about the style or about the dominant physician styles or about a dyadic concordance present or absent?
Uh,
I asked the question. I'm happy
yes,
to
go ahead.
clarify. Hi.
Sure.
I just was, it would be nice to sort of like maybe a figure, maybe it's in the manuscript, but like a nice example of like, oh, this was something that our artificial intelligence system like noted was discordant, and like we can read and like, oh, like, and then something that I could internalize as a provider,
Sure.
like, oh, this was something. I see how they captured this.
Yeah, so I don't have that in the slide now.
Or like maybe just off the top of your memory, something.
Yeah, I mean, what I can tell you is we didn't use AI to measure concordance or discordance. What we used the AI to do was to develop two similar but not exactly parallel measures, one of patients' health literacy, the other of physicians' linguistic complexity. And using a variety of techniques, we categorize them as either high or low. High health literacy, low health literacy, high complexity, low complexity. We also, in addition to using AI, we used expert rating. So representatives of patients, representatives of physicians, each of whom sort of examined the validity of these measures based on their own interpretations. And we found them to have very similar prediction ability. Are these subtle differences that you will see if I were to put up examples in terms of concordance and discordance? I would say for the most part, they are not subtle. However, you can imagine with any categorical outcome, if someone is right at the cusp of being between low and high, and a doctor is right at the cusp of being low and high, it may actually be closer than a discordant assessment would make. So it certainly was, we did not look at this in a linear fashion. There are a variety of reasons why we couldn't do that. But for the most part, I'd say most people would agree that sounds like that's just way too high for a patient. Or in some cases, it sounds like that's way too low for this patient. The patient's asking at a much more sophisticated level.
Thank you. Dr. Sheridan, well, you had a question about training providers for tailoring. Go ahead. Mm-hmm.
Yeah, I think there's a question from Sheila in there I think it comes a little bit before that. Dean, do you have any recommendations for a health literacy screening tool, that you prefer, that works in a clinical setting, that works in a research setting? What are some of your preferred tools? I know the Common Data Element working group is trying to include health literacy measures within our common data elements that the whole initiative is going to be collecting. But I wanted to get your opinion. What are some of your favorite health literacy screening tools in the clinical setting and then in a research setting?
Mm-hmm. So this is a very controversial area that you've tapped into. It's controversial from a measurement standpoint, and it's controversial from a clinical standpoint. I don't happen to be someone who espouses the need for screening for health literacy in clinical settings. I believe that any attentive clinician will be able to make that determination in the course of their work. But some do advocate for health literacy screening clinically, and certainly there's a need for measurement and research. For those who are interested, I would recommend looking at the Health Literacy Tool Shed. It has over 100 health literacy measures and their strengths and weaknesses. One of the reasons that I developed this health literacy tool that uses an algorithm is the need to, in an automated, rapid, and confidential manner, be able to measure the health literacy of a patient without having to do any undue burden on the clinician or the patient, including the stigma and shame. So, it is possible if patients have written anything that we could actually generate a health literacy measure on them. If I were to pick one thing in a healthcare setting to do, and I was allowed one question, I would use the question, how confident are you filling out forms that you get from this healthcare system? That one has shown to be quite easy to administer, has good validity in English and Spanish speaking patients, and seems to track well with other more intensive health literacy instruments. The problem with health literacy measurement is it's very difficult to do if you're not doing it as a test in person, so it tends to be resource intensive.
Great. Thank you. I think that's a really healthy perspective. Based on some of the findings that you presented to us, particularly about the link to positive outcomes from provider communication tailoring, I wanted to know, like, are there any effective training interventions to teach provider communication tailoring that are out there that might be a resource for individuals wanting to include something in one of our disparities reduction interventions? And I can imagine also, as a provider, I know if we had algorithms for health literacy screening that we could do on our panel on existing communications, that might actually be something that could be drawn into a training interventions, like, okay, here's the need within your patient panel, but back to that original question.
Well, it's interesting.
Are there training interventions?
Yeah, I'm not aware. So let me just say, in the field, there has been a very strong movement towards not universal tailoring, but universal precautions. That's the predominant teaching philosophy, is assume that everybody has low health literacy and communicate accordingly. And you can imagine there's a public health logic to that. And it makes it more simple in a way for a clinician to just assume that everyone has limited health literacy. I think what we showed is that's fine. It doesn't seem to be any better than not doing anything. That what really seems to be best is, in this precision communication way, to try to tailor your communications accordingly. So I'm not aware of any trainings that do that. I will make two other comments. One is that most physician trainings around communication focus on what to say, how to say it. They very much focus on the expressive part of communication as opposed to the receptive and listening part of communication. And I think what's exciting about our work, I think, is it provides more impetus for trainings to focus on the listening function and making sure that you're not making assumptions when you listen, making sure that you really understand what you're hearing and then can make other inferences about what this may mean to when you do decide to express yourself. So I think it's an area for research for sure, and intervention. Finally, we've taken the one step since we finished the study to actually test an automated feedback system to doctors as they're writing their secure messages. And we did this using a simulated electronic health record with simulated patient scenarios, high literacy, low health literacy, et cetera. And we found that the automated feedback system, which essentially pinged doctors to say, like, yo, that's a little bit too complex, you might want to do this or that, was actually both acceptable and led to more understandable secure messages at that message level, but also the docs learned over time to not have to be triggered by that warning, that they got better over time in having more tailored communication. So we might be able to use some simple triggers to help people learn on the go.
Great. We have a hand up.
Yes. Yeah, go ahead, Mandana.
Dr. Opara?
Yes, thank you. Can you hear me okay?
Yes.
Yes, we can.
Awesome. Thank you. This was a great talk. My name is Dr. Ijeoma Nodim Opara, calling from Detroit, Wayne State University School of Medicine.
Okay.
I want to appreciate two things and I have a question. I want to appreciate the comment you just made here, where you lifted up the need for us as physicians to improve not just the expressive piece, I absolutely agree with you, but also the receptivity, the ability to listen, and then the word you used in your presentation, adapt accordingly. It's the dexterity in the interaction that I particularly appreciate that you lifted up in the conversation. So I really thank that. And the second piece I appreciate is also the commentary about matching. It's about matching, fitting, to the patients, and it's not a one size fits all. And so I really appreciate that, which is why it makes total sense that you don't recommend a particular screening tool, because it really is about listening and learning the particular patients and then adapting accordingly. So thank you for that. The question I have is around the sort of opportunity for, should I say, digital inequity or technological disparity here with your use of algorithms. We have learned a lot about how bias can be coded into algorithm, and it's, you know, the machine learning is as good as the training data that is utilized in it. So I would like you to talk about how you accounted for that as you developed out your algorithm for your study. You know, in what ways did you either prevent that, account for that, minimize that, mitigate against the impact of that, or not?
Thank you. Well, thank you for the compliment and for your question. First, I just wanted to riff off the statement you made about the importance of matching. And I think it made me think of the prior question related to physician trainings. And I think, you know, what your comment made me remember is that there's a whole line of physician training that is about improvisation. You know, training's actually done by actors to clinicians about the importance of, you know, improv theater. What you do is you listen and you react, like you just kind of go with what you're hearing. And it's a very intensive exercise in attention and listening that then drives your response. And so I think there are some very effective training modules of bringing actors expert in improvisation, teaching physicians to improvise as part of their communication skills.
Dr. Schillinger, are you talking about yes and the exercise?
Yes, exactly.
And?
Yes,
absolutely. I completely. And just so you know, the other hat I wear is in performing arts, so I'm not surprised. I am digging everything you're saying.
I'm not surprised, and I think giving people the space to say, you know what, it's okay for you to step out of yourself a little bit, and you don't have to be that same rigid person every time, is liberating. The second question is a very important question, and it brings me back to the issue of measurement. So I have written about this quite extensively. Part of the problem of literacy measurement is embedded in an implicitly racist context, both a history of racism, but also a history of scientific hegemony. Who gets to decide what is the right way to say something, or what is the way of saying something that sounds literate? Who gets to make that decision? Well, it's the dominant culture that makes that decision. So there's a tremendous amount of implicit bias and explicit bias in how we even measure literacy, leaving aside health literacy, just literacy as a whole. In addition, there's a tremendous problem with, I think, what the term is attribution bias, which is you measure someone as having low literacy, for example, and they also have these health consequences, but you attribute those health consequences to the low literacy rather than the systemic drivers that are present in that person's life that has led them to have limited literacy skills, and you misattribute their poor health to the literacy rather than the drivers of the low literacy. And so that attribution bias needs to be carefully attended to as we think about health literacy. In the current study that I shared with you, our work is not immune to some of that bias. We are assessing people's language using established linguistic indices that measure complex constructs like text cohesion and other language attributes that have been developed with presumably the King's English in mind, or some English in mind, right? And those indices, we don't know whether and to what extent they have been validated with diverse populations or are sensitive to those diverse populations' way of speaking or writing. Now, we attempted, as you pointed out, to, I wouldn't say mitigate, but to examine the degree to which that kind of bias might influence the validity of our findings in a couple of ways. First, we tried to involve members of these communities in the expert rating process to see if the linguistic indices themselves were picking up language in a similar way to which they as community experts would, and we found that indeed they were. But further than that, we we examined the validity of these measures across various health indices and communication indices obtained on survey and through electronic health records to see if the performance of these measures varied by race ethnicity. And we found that they performed equally well across race ethnicity with 5 racial and ethnic groups in this large data set. So I can't say that there is no bias in these. I think there is bias, but I think the bias that we have to deal with here is the attribution bias of whether or not we believe that the health literacy measure itself is responsible for the poor health. And that's, I think, the biggest pitfall concern in our research. The fact that we show that discordance does, in fact, seem to relate to patients' experience tends to mitigate that concern, but not fully. Hi, Dorian. Sorry, I see you.
Hi, Dr. Muriel, please ask your question. Go ahead.
Thank you so much, and good to see you, Dean. You gave an example with the chocolate mouth poem of patient engagement in public messaging, chocolate smile rather, with a young person. I was wondering about thinking about implementation science and the issues around communication with public health messages for an older population with chronic health conditions. I think it's particularly relevant to many of us that are working on the P50 and hoping you can address that question.
So what's the question, Dorian? What would be your question in that regard?
So the question is being able to engage an older patient population around public health messaging in a way that speaks to that older patient population. The chocolate smile example is someone that is younger.
Yeah, well, it's interesting. I don't have a definitive answer for you, obviously, because older people come in lots of shapes, sizes, and cultures and all of that. But I will say what's been remarkable about the Bigger Picture campaign is the degree to which it resonates with older people as much as it does with younger people. In fact, many of the poems display or feature a young person with her grandfather or a young man with his father. And there's a lot of intergenerational kind of conversation that's happening in these pieces. And I think what I've taken home in part from that project is how art and artistic expression in all of its forms can reach everyone in meaningful ways. And certainly spoken word poem, it's accessible to older people. It's video, it's audio, the demands on the viewer are the demand of any entertainment, which is a minimal demand. It's, can I grab your attention? So I don't have a definitive answer for you in terms of the older population and public health communication that would be any different than probably what I would say for a younger audience.
Great, thank you.
Great. Well, thank you very much.
And Dr. Opara may have something to say about that too. I don't know.
No, I completely agree with you. I have found that poetry, music, these are transgenerational, and we don't do it enough in our work as researchers and scientists, physicians, clinicians, in academia, and we need to do more of it. We need to incorporate the arts and humanities more in this work to truly communicate. That's what I think. And
I agree.
It truly is transgenerational. It really is.
Well, thank you, everyone. We are at the top of the hour, and we wanted to again thank Dr. Schillinger for your incredible presentation and such outstanding, engaging talk. Thank you again.
Thank you for inviting me. Good luck, everyone.
Bye-bye.
Bye,
Thanks,
Dorian.
Dean. Thank you, everyone.